So I've been podcasting for the better part of a year on OCD Straight Talk, and the other day a listener wrote in and asked me a question about, in effect, the usage of cognitive therapy techniques for the purpose of refuting obsessions. That is to say, intrusive thoughts within the OCD construct. So indicating that, some clinicians and life coaches, he stated, are sort of endorsing these technical processes as effective, and asking, hey, what do you think about that? So I thought it was a great question, and I decided to go ahead and do an episode or a podcast or whatever on the question. But I wanted to go ahead and also launch a channel, a YouTube channel, and and begin to talk about OCD here too. So like I say, I've been podcasting for a while, but not everybody checks out podcasts, right? Some people just kind of do the YouTube thing, and that's cool. But the point of the podcast, for as long as I've been doing it, has always been to try and provide evidence-based, empirically supported information to the general population. So in other words, we're not necessarily regurgitating and consuming the professional literature on this channel. We're just working to explain in really simple terms the basic idea of how we unravel the code of OCD, how we begin to actually make real progress. So the first I should say the first sort of punchline of in answering the question, how do we begin to make progress, is, well, we go to see an OCD specialist, right? We go to psychotherapy, and not just anybody with credentials behind their name, because the truth of the matter is, as unfortunately many people know, is just because you have clinical credentials does not mean you're going to help people to get better when it comes to clinically significant anxiety symptoms. Some people are able to do that. I don't mean to say universally that's the case. No, of course not. Some people are. But the truth of the matter is that the vast majority of individuals who specialize in the effective treatment of anxiety disorders and OCD have long waiting lists that are comprised of other clinicians' clients, right? So hate to say it that way. That sounds kind of like a rude or a mean thing to say. But the point of the matter is, there are lots and lots and lots of people around the world that are suffering from ongoing symptomatology without any real hope of being able to get better. They've lost hope. And they've lost hope because they've tried. They've tried everything that they've read on Billy Bob's blog post. They've been to therapy before. They've been processing unconscious wounds or whatever it might be. And still the symptoms remain. Still, they're heckled by these obsessions and compulsive patterns. Still they suffer. So, and so there's the question of, what do we do, when it comes to, to clinically significant anxiety symptoms. So like I said, this individual wrote in and asked the question, what's your take on this idea of using evidence and reason to dispute intrusive thoughts? And again, it's a great question. And it's a great question because the vast majority of the clinical community works that particular strategy. The problem is when you're looking at the heartbeat of the evidence-based protocol for OCD, that is to say exposure and response prevention, you're not going to see a whole lot of disputing. That's just not really there. And it's not really there because disputing generally tends to be compulsive. Now, some of you may feel a little bit confused as to, well, what do you mean by that? Compulsions drive the OCD. They are the gasoline in the tank, right? If you remove compulsions from the OCD system, if you remove the C, as I often say, from OCD, it ceases to function in the same way, right? It really doesn't function quite well at all. What we begin to see is the unraveling and the falling to pieces of the symptom set. In other words, it's effective treatment. To remove the C from the OCD is effective treatment. Of course, there's a big caveat to that, and that is, well, individuals have to be able to identify their compulsions in order to stop them. We can't just sort of like, give this some sort of like great advice to just stop compulsions, because the simple fact and the unfortunate fact is OCD is a sly beast, right? And it's oftentimes just as smart as individuals are. And we say, oh, I'm going to stop this behavior because I identified it as a compulsion. Well, 15 minutes later, OCD has already manufactured a new one, and the individual hasn't really identified that behavior as a compulsion. He or she's just sort of doing this new thing, and it can be as simple as like kind of playing with their hair when they're nervous, and they're playing with their hair, and they're not identifying that as a compulsion, right? And the general population would be like, what? That's no, it's messing with the lights or whatever, It's not messing with my hair. It's checking the locks. It's turning the light switch on and off. And, these are like highly stereotypical compulsive patterns. So those are compulsions, not these other things. And that's exactly what OCD wants you to believe, that these other things have nothing to do with the OCD. OCD's happy for you to continue believing that, because that means the OCD continues to function. You're giving it C's, right? So that's what it wants. It wants the C so that it can function as OCD, right? Anyway, I'm kind of getting off topic here. So how do we really begin to let go of the intrusive thoughts, and can we use reason or evidence gathering and weighing for the purpose of quote unquote disputing them? Well, in the cognitive tradition, that's exactly what we work to do. We'll kind of weigh evidence for or against the veracity of a thought, for the purpose of trying to restructure the cognition and to render it more functional or less dysfunctional or less, emotion inducing or whatever it might be. And there's nothing bad about that. There's nothing wrong with it. There's certainly, if you look at something like David Barlow's Clinical Handbook of Psychological Disorders, he's going to go through lots and lots of outcome data for the treatment of different anxiety disorders, including OCD, and show that, yeah, there's good research that supports the usage of cognitive therapy for the treatment of OCD. Are there more effective models? Well, that's something that he gets into and shows, yeah, the outcome data actually demonstrates that exposure and response prevention renders superior results comparative to something like cognitive therapy, or a synonymous term would be cognitive behavior therapy. So something like CBT renders, generally speaking, inferior results to something like exposure and response prevention. Although, in fairness, let's say it this way, exposure and response prevention is kind of a grandchild of CBT. So it's not like they're fundamentally, different modalities or interventions or therapeutic schools of thought. They're not. In fact, we would say that exposure and response prevention, in particular, and exposure therapy in general, is really kind of a diagnosis-specific application of CBT theory, right? It's the same stuff, but it's taking the cognitive model that is sort of the heartbeat of cognitive therapy, and applying it really specifically and in an effective way to the treatment of OCD. And in doing that, what it leaves out is evidence weighing, right? And so we're not necessarily looking to weigh evidence or looking to dispute thoughts, because again, that's exactly the role of a compulsion. That's what a compulsion does. The compulsion seeks out certainty. A compulsion tries to get rid of the thoughts. It tries to reduce the anxiety. It tries to manage the whole thing in this pretty maladaptive way. And that's what a compulsion is. That's what a compulsion does. So we can sort of talk about how to identify compulsions from within the context of all of these adaptive behaviors throughout the day in a separate video, I suppose. But that's something that we've talked about on the podcast. So again, feel free to check that out. But generally speaking, we're not working to employ some sort of evidence gathering and weighing or disputation process, because it does tend to be compulsive for individuals. So instead, what we're working to do is to sort of embrace the idea of uncertainty that is inherent to the intrusive thought material, right? So let's take an example of contamination OCD. Maybe the popular term would be germaphobe, kind of a rude, synonym. But I mean, that's maybe for some individuals in popular usage, probably more so than contamination OCD. Probably some people are like, what is that? But most of us know this other term, germaphobe or germophobic or germophobia or whatever. Anyways, so, a kind of a good situation, a good example of a situation in which an individual's contamination OCD might be activated is if, let's say, the individual is in a public place and the individual goes to open a door and touches the door and opens this sort of public door. And, for whatever reason, maybe she doesn't feel there's another choice, or maybe she forgot her napkin, or, whatever. That is to say, some individuals might be sitting here thinking, well, I wouldn't touch the door to begin with, which, would be an avoidance compulsion. And that makes good sense, right? Lots of people will just sort of work to avoid the whole thing. But anyway, let's just suppose she did it, right? So she opens the door. And in opening the door, she has an intrusive thought now, my hands are dirty, right? Maybe she feels some sort of like greasy substance on the handle, or maybe, or maybe she just has the thought, this is filthy and my hand is dirty now, right? And then she sort of feels this almost like this sensation on her hand that is a sure enough piece of evidence to her, or a trigger to her. Dude, your hand's really, really dirty now, right? And then her anxiety is increasing. She's feeling really, really anxious and uncomfortable with not only the situation, but the thought that says, my hand is dirty. And then what does she do? Well, what is she going to do with the thought, my hand is dirty, having touched the doorknob and now, or the handle, and my anxiety is increased? Well, she's naturally going to go and grab some hand sanitizer, right? Or she's going to go and, wash her hands, or she's going to pull out that trusty napkin thing and not put herself in that position to begin with. So fine. So there's these compulsions that she's going to work to engage. But let's suppose she doesn't. Let's suppose she happens to be in therapy and she knows the golden rule for beating and unraveling the OCD system is stopping the compulsions. Let's suppose she's just somehow she knows that. Oh, I'm not going to do that. That's a compulsion for me. I'm not going to do it. Great. So she kind of muscles her way through that, and she's like, no, I'm not going to do it. So she's left with this thought, right, and the anxiety, and she's like, oh man, this is terrible, right? But I'm not going to do that. So there's the question, how does she let go of the intrusive thought, right? How does she kind of move on past the intrusive thought? And again, without engaging the compulsive pattern. That's a great question. I would say this is probably the question that brings people into therapy to begin with for OCD, is how do I let go of my intrusive thoughts? This is like one of the most popular or most frequently asked questions, at the top of cases, is how do I let go? How do I dismiss? How do I get rid of these, these awful obsessions? And so there's a couple of different really, really good answers to that question. And in therapy, I generally will try and work both of these strategies for patients. So I'll try and help them to learn, to become acquainted with, and to become adept at engaging both of these strategies or processes for the effective treatment of the OCD, and again, the letting go of the obsession. The first one is going to be called exposure statements. Now, I need to say sort of off the bat, I didn't develop exposure statements. I've Googled exposure statements before, and you don't find a whole lot. So it's not something that was developed at the University of Pennsylvania, or that or something like this. It's something that appears to be much more of a sort of a personal invention, if you will, if I can kind of say it that weird way. but I didn't develop it. As brilliant as I think exposure statements are, and as I say, after many hundreds of cases, I always teach and use exposure statements. So, having said that, I don't mean to give inappropriate credit to someone, but as far as I know, Dr. Monica Williams developed exposure statements. Like I say, I've been around the block a little bit, worked with a lot of different OCD specialists, and nobody really ever seems to know what these are. And like I say, if you sort of comb the professional literature, it's not really in there. So maybe she didn't develop it and I missed it. It is in the professional literature, but nope, I don't think so. I think this is Dr. Williams' sort of invention. Again, if I can use that sort of weird language here. Props to Dr. Williams. So, okay, anyway, the exposure statement is essentially maybe, maybe not. Okay, maybe, maybe not. And after the first maybe, we're dropping in the thought. So it's a sentence, maybe, maybe not. And in between the maybes, there's a blank, right? And in the blank, you drop your thought. Maybe the thought is, I'm dirty. Okay, maybe I'm dirty. Maybe not. I don't know. Maybe the thought is, you're going to get sick. Maybe the thought is you're going to get sick. Or you're going to have the stomach flu, right? Okay, maybe you're going to have the stomach flu. Maybe not. I don't know. Or maybe it's a visual. Maybe it's an image. You see yourself vomiting, kind of like this horrible night of vomiting. And it's just, terribly anxiety producing, and you really want to go wash your hands. But no, I know that's a compulsion. Okay, maybe I'm going to spend the night vomiting, but maybe not. I don't know. I don't know what's going to happen. So this basic idea. So this is a really, really versatile strategy. We can kind of take any word obsession that pops into our mind, and it can be any subtype or symptom dimension of OCD, from a sexually taboo fear to like harm OCD, like I say, contamination OCD, relationship or existential OCD. I mean, it can be lots and lots of different examples that we can use in a very versatile intervention. Maybe not. I don't know. And for some individuals, it's images, right? They see images, and like I say, one example might be they see an image of themselves vomiting, like in the case of something like emetophobia, right? So they see, oh no, it's causing terrible anxiety because they see themselves vomiting. It's very, very upsetting. And so we might use something similar. Just because I see myself vomiting doesn't mean that's going to happen tonight. I don't know. I don't know what's going to happen. Something like this. So again, we're sort of speaking back to the intrusive thought, infusing it with uncertainty. We're really emphasizing and majoring on the idea of, I don't really know. Maybe that's going to happen. It certainly could. But just because it could doesn't mean it will. I don't really know. And really beginning to work that logic through, just meaning using the logic, and letting it soak in your mind until it really begins to sink in and make sense to you, right? So in other words, what I'm trying to say to you is that'll probably feel like a pretty flimsy intervention for you the first time, second time, third time you use it. But I would encourage you, hang in there. Hold on, hang in there. Let's use the exposure statement, right? That's the term that we're going to use here. Let's use that skill, the exposure statement, and we're going to use it enough times. I've certainly had some individuals say that really doesn't help me. But the fact of the matter is, if I had to put a percentage on it, I would say something like 87 to 95%, maybe more than 95%, but let's say 87 to 95% of individuals that I've personally worked with. I can't speak, for other clinicians, but I've personally worked with and to whom I've taught exposure statements have subsequently said, man, that was a game changer. That was really, really helpful. So again, maybe not. I don't know. That's the basic idea of the exposure statement. That said, that's the first sort of intervention. And again, I'll work to use both of these. The second one is behavioral modification. Now, what in the world does that mean? Well, if you go back to the evidence-based protocol, the really, really well-researched gold standard a psychological modality for the treatment of OCD, it's exposure and response prevention, or EXRP. Sometimes it's written ERP. But in any case, exposure and response prevention, EXRP, the idea is exactly that, RP, right? It's response prevention, right? So that's the behavioral modification element of beating the OCD. It's pulling the C out of the OCD, right? It's identifying the compulsive patterns and working methodologically and consistently to stop them, right? Remember in our analogy, the young lady who opened the door sort of muscled that compulsion into submission. She knew, oh no, I'm not going to do it. I'm not going to do it. She recognized she has choice here. She doesn't have choice with regard to the obsessional material or the anxiety that follows. She can't control that stuff. She can't control the O, right? The obsessions are going to happen. Intrusive thoughts are going to happen. They're intrusive thoughts. They're going to happen. But then the compulsion piece, well, that's a choice. I don't have to do compulsions. I don't have to do compulsions. I can not do those, right? It may be very hard, but at the end of the day, it's simple, right? It's not easy. It's simple, right? It's simple to say, I have control here and I'm not going to give into the compulsion, right? Again, not easy to do that. If you've ever worked that, you know, that's not easy. That's not easy stuff. But is it simple? It is simple in the sense that I have choice here. I can not do the compulsion. I can muscle my way into behavioral change here. Again, not easy stuff. It is simple though. Let's not make it complex to say, oh, well, I can't really choose. It's kind of the OCD's happening to me. No, not in that sense. In that sense, you're happening to your OCD, which is beautiful because if you're happening to the OCD, right, you can stop happening to the OCD, meaning you can stop engaging compulsions. And when you stop engaging compulsions, what you are going to find is that the whole symptomatological set begins to unravel and fall apart. In other words, your obsessions will decrease in frequency, your anxiety will decrease in severity because you stopped compulsions, right? You forced them into submission, and over the course of time, I'm not talking 5 minutes, right? Not talking 5 minutes. I'm not talking 10 minutes. I'm talking like a day. I'm talking like 2 days. I'm talking like a week of consistently fighting to not give in to compulsions, minute after minute, hour after hour, consistently working to identify and stop compulsions. If you're able to do that, and again, it's not easy, but it is simple. I can stop the behavior from happening. And when I do that, yeah, you will find that the intrusive thoughts decrease in frequency and that the subsequent or related anxiety does decrease in severity. So in any case, the longer and I think more substantial, certainly better documented and well-researched answer to the question of how do I let go of intrusive thoughts is, well, we force compulsions into submission, right? We stop the compulsions, we stop the responses. Again, to go back to the evidence-based protocol and the name of it, exposure and response prevention, right? So we're preventing the responses. Again, the challenge is we have to be able to identify them. So often OCD is a sly beast, right? And I think I've got all my compulsions, identified and stopped, but still my anxiety is really bad. And I've been at this for like a week, dude, and it's just not, I feel awful. My thoughts aren't going away. Okay, I've heard that story a number of times, and I'll tell you from clinical experience, you don't have all your compulsions under control. You think you do. I'm not saying you don't think you do. You think you do, but you're wrong, right? You're wrong. So you have to be able to go back to the drawing board and look for the behaviors that you're engaging for the purpose of getting rid of thoughts, reducing anxiety, and seeking out certainty of some kind, right? Those are usually where your compulsions are. Again, I'll do another video on that sometime soon, how to identify compulsions. Because that's really the punchline. I mean, you can say, I'm going to stop the compulsions, in correspondence with and in keeping with the evidence-based protocol, but you got to know what they are, right, in order to do that. And that's really where your money's going with psychotherapy. That's why you hire a specialist, is what I'm meaning to tell you, because a specialist is not just going to help you to identify your compulsions. More importantly than that, a specialist is going to teach you ongoingly how to identify them in the future, so you can not only make progress but maintain it on your own. Right? That's really the that's whatever. That's why you go to see a specialist. So anyways, so again, how do I let go of my intrusive thoughts? I'm not using reason, right? I'm not weighing evidence for the purpose of disputing thoughts. Again, all that just feels compulsive, and certainly is. But we're using the uncertainty that is inherent within the thought process to our advantage, saying maybe that'll happen, but maybe it won't, or maybe I am dirty, but maybe I'm not. I don't know, right? And really just sort of letting it sink in. I don't really have any way of knowing that stuff. There isn't any. It may make sense to me. I may be able to say, yeah, that assumption makes a lot of sense, but we're not talking about assumptions here, right? We're talking about brass tacks and facts, right? How do I know that I am dirty? How do I know that the bacteria on the doorknob transferred to my hand? Which bacteria? How do I know that those bacteria are foreign to my body and that they're not pretty common to my immune system? How do I know that? I don't. How do I know that the bacteria that are on my hand somehow are now in my body, and that they're going to cause some sort of sickness response? Again, I don't know that. I don't know that. So I'm sort of faced with the uncertainty. So I'm using the uncertainty to my therapeutic benefit and advantage. Maybe, maybe not. I don't know. And then we're working to use that as a springboard into effectively forcing the compulsions into submission. So that's the basic answer to the question, how do I begin to let go of my intrusive thoughts? We're using the technique, but then more importantly than that, we're working with all of our might to consistently produce behavior change with regard to the OCD over the course of time. So I hope that is a helpful answer for you. So feel free to check out the podcast if that feels helpful to you. Again, OCD Straight Talk is the podcast, and I hope that the answer is helpful to you as well. Feel free to hit the like button, leave comments if you wish, subscribe to my channel, and any questions you might have, I'll do my very best to answer them in the future. All right, thanks.